when they work with anesthesia for thoracic, they ask in the middle of the procedure, can we take the bronchoscope outside? Can we take the bronchoscope to other rooms? Let's focus in this, we'll focus in this lecture about the role of fiberoptic in the thoracic anesthesia and light isolation. So we start with anatomy and with some technical issues with the bronchoscope, and you know it all. And we'll go to the technical issues with the lung isolation with different types of lung isolation tools. And we'll then go to the importance of fiberoptic bronchoscope, why we need it all over the procedure, and what can happen without fiberoptic bronchoscope. Starting with anatomy, this is the bronchial tree. We have the trachea with 19 millimeters diameter with almost 13 to 15 millimeters, 15 centimeters. You can see clearly here that the right main bronchus is quite short compared with the left side, 22 millimeters or 20 to 20 millimeters according to the height of the patient or the person. And the left main bronchus is quite long, 50 millimeters. Left main bronchus plays some role with the choice of the double lumen tube. Its diameter can be measured by the CT scan, on the CT scan. In the left side we have two loops, anterior and upper and lower. In the upper we have the upper apical loop, and we have the longula here. And then we have in the lower loops we have 5 bronchus. In the right side we have right upper loop comes separately, then right bronchus intermedius, then it gives anteriorly the middle loop, then we have 5 segments in the lower loop. This figure shows you that on the left side you can see mainly anteriorly. If you look anteriorly, you may see only the upper loop. Only small part of the lower loop is visible here, because the lower loop it's not one above the other. It's the upper loop is above and anterior and medial, while the lower loop is posterior and lower and little bit lateral. This will give the figure. When you see the bronchoscope, you see the left upper loop in the lateral, upper, and little bit anterior, while the lower loop is posterior and medial. On the right side, we can see the upper loop clearly. Middle loop is anteriorly. Now, if you look at the lung from behind, you will not see the middle loop at all. You'll see only lower loop and upper loop. Lower loop is bigger than both, but you can see only small part anterior. This plays some role with orientation when we do the bronchoscope. Where is the goes? Where the bronchus? Anterior, lateral, medial, like this. This is the lateral view of the left side. Now this is anterior. You can see the upper loop, and you can see the lower loop. This is the right side. Upper loop comes anterior and upper side. Middle loop is anterior, while the lower loop is the lower side and the posterior side. This is the segments of each loop. We have 3 segments in the upper loop. It gives the Mercedes shape or trifurcation of the upper loop when you look up there. This is very important. We'll see it in the next slide. We have 2 segments in the middle loop, 5 segments in the right lower loop. On the left side we have apical posterior and anterior of the apical loop, upper loop, and we have the lingula, superior and inferior, and we have 4 segments in the lower side. On the right side we have 5 segments. Sometimes we have some anatomical variations, but it's not all the time. Now we have to know the adjacent structure about in the trachea. We have the aortic arch, we have the esophagus posteriorly, and we have the zygous vein. Usually, whenever you have patients for thoracic or for lung resection, you have CT scan. So we look at the CT scan, we never look at the report. The report is not important for us because the report will not focus on the airway and the distribution of the airway. They focus only in the pathology in the lung or anywhere, but they never focus or give you hints on the upper airway. Why we have to look in the airway? Because there will be some anatomical change or anatomical variations, which is normal, like the emergence of the right upper loop. Right upper loop, sometimes it comes from the trachea, not from the right main bronchus. It comes from the trachea. If you know this, then isolation of the right side, right upper loop will be a little bit tricky. Now, this is a healthy 25 years old person. This is the normal bronchial tree, but with the age and with the smoking and with COPD, you have to see anatomical change, which you have to know if you want to do fiberoptic bronchoscopy or you have to do lung isolation. This is 60%. You will see there will be notch here, C-shape, sometimes more if the patient is older, and at the side of the aortic arch, when it becomes calcified and push the trachea to the left side, so it gives the C-shape. You'll see it in the next slide. Gives you. Now, if you look at the cross section of the trachea, usually it's half circle. Now, with the aging and with the smoking, it will be longitudinal like this. So, if you put the NG in the double lumen tube, the chance that the bronchial lumen go to the right side is quite bigger. So, you put double lumen tube, it will not go left side, it may go to the right side. Both go right side. So, if you know this, you can find out why the bronchoscopy is very important. This X-ray or CT scan. Here you can see the trachea, and this is the right upper loop. The CT scan, the right side and the left side. This is right side, this is left side. This is right upper loop bronchus. It comes from the trachea. Now, if you put the double lumen tube, the bronchial cuff will come here. Then the right upper loop will not be isolated. If you want to isolate the right side, it will be inflated all the time. Now we have to prepare the patients for successful fiber optic. This is usually just general things for fiber optic. Usually comes from difficult intubation and fiber optic intubation more than in the thoracic anesthesia by preparing the patients, glycol relate to the previous secretions, and you have to get the tower, the whole tower with the whole instruments of the bronchoscope. And sometimes if you have blood, or you have high secretions, then you need oxygen blower to open the way for you, not only to use the suction. They have the patient pulmonary hemorrhage and putting blood all the time. You will not see anything about fiber optic. So we use oxygen to blow away and see the good view. This is the tower, you know it much better than me. The bronchoscope has camera channel. This is objective lens. We have two lights, and we have lumen for suction and for insertion of the cathode. The tip of the bronchoscope is moving anterior and posteriorly with 120 degrees centigrade with the use of, this is the proper, there is a tube here actually, we are not talking about the awake intubation. So you have to keep the bronchoscope straight all the time, and this is how to, you push down the knob, the tip will fix up and vice versa. Now we have to be careful that with the single lumen tube, as we say, the anatomical change of the bronchial tree, the first hole you see while you are setting the bronchoscope is the Murphy eye, because the bronchial tree it's not straight. So the bronchoscope goes through the Murphy eye, then it will be stuck between the wall of the trachea and the tube. It may injure the bronchoscope. I just stop here to have just yes. This is simulation in the thoracic anesthesia side of Dr. Peter Slinger. I get the permission from him to have to present this in my presentations. And this is the bronchial tree, and this is our bronchoscope here in the trachea, and this is the view which we see when you put your bronchoscope in this area above the carina. Then we go to the right side. Okay. So what we have done, we rotate the bronchoscope to the right side, then we flex up. Okay. This is the bronchial tree, right main bronchus, and here in 12 o'clock, because we are rotating to the right side, in 12 o'clock we'll see the right upper loop, and here is the bronchus intermedius. This is right upper loop, this is bronchus intermedius, and this is a typical view of the right upper loop, Mercedes shape. Now we return back our bronchoscope anteriorly and posteriorly. Then we can see the middle loop here. As you see the X-ray or the previous figures, the middle loop is anterior. So the bronchus of the middle loop will be anterior. The lower loop is posterior. And this is the B6, which we call the upper segment of the lower loop. This is the most difficult segment we can access with a bronchoscope. And if you go deeper, you will see the four segments of the lower loop. Now I'll go back to the trach. Then we go to the middle loop. To go to the middle loop, you have to rotate your hand to the left side. Then flex up and go to the left main bronchus. You can see it's quite long if you compare it to the right side. And inside, you will see what they call it secondary carina. Here, because the upper loop with the lingula, it's almost equal to the lower loop. So they have the same diameter of the bronchus. Inside, you can see two, one for the lingula and one for the upper loop. Now this is lower loop, it's medial and posterior, and this is upper loop is lateral and anterior. Now we'll go back to our presentation. Now these are the main techniques of double lumen tube. Double lumen tube is the lung isolation. Sorry, double lumen tube is still the cornerstone of lung isolation. It's still the standard. And before the when we don't have other means of bronchial blockers and univents, Fogarty had been used, but Fogarty has no lumen, has only lumen for the cuff. So you cannot apply oxygen or you cannot do suction. It was used for lung isolation, and we'll talk a little bit in details about double lumen tube. You know all the double lumen tubes. We have two lumens. With the if you have cross section, it will be half circuit, D shape. It's not round shape. We have bronchial lumen and we have tracheal lumen up in here. Two cuffs. Usually the tracheal cuff is white, and the bronchial cuff is blue. And we used the left double lumen tube, 99%. Actually, the only indication for the right side double lumen tube is when you have a procedure in the left main bronchus, where you cannot insert the left double lumen tube. You have to insert to the right side because the procedure in the left main bronchus itself, or in the carina. How we insert it? We all know that there is a stent usually in the tube. We make a curve that the bronchial lumen is upward. Once it passes the vocal cords 90 degrees to the left side, then it goes by itself to the left side. Although we still have some cases that it goes to the right side, as I show you, because of the anatomical variations. And then, when we put the tube, first of all, we inflate the tracheal lumen. We auscultate both lungs. Then we do the bronchoscope to confirm the position. So first of all, we go the bronchoscope at the right in the tracheal, or the right side tracheal. We have to confirm that what we are seeing here on the right side is the right main bronchus. It's not the left main bronchus. How we confirm it? We have to go in and see the right upper loop, the figure of the right upper loop, which has trifurcation of the right upper loop, which is typical for the right side. Here we can see the trifurcation of the right upper loop. We go in, we see it, that this is the right side. Then we go back to the tray and we confirm the position of the cuff. We see the crescent shape of the cuff after inflation. Okay? Now to confirm it more, you have to go with the bronchoscope to the left side and see the secondary carina. Okay? This is where the cuff, it's clear in the trachea. It's a little bit herniated, so it needs to be pushed in. And this is another figure. The bronchial lumen is pushed too deep, and sometimes it goes to the middle of the lower side, so the upper side will not be isolated. So, and we have seen the case last week with Koishan. Okay, so this is the proper position. Now sometimes, whatever you do to insert the double lumen tube, it goes to the right side. So what we do, we put the double lumen tube, the bronchial lumen, in the trach. Okay? Then we go like this. We put it in the trach. We didn't push it in. We just keep it in the trach. Now we go with the bronchoscope on the left side, bronchial lumen, and we put our bronchoscope on the left side. Then we slide our tube. So it will go by nature to the left side. Okay? Many studies have been made to confirm what's the proper size for the double lumen tube. They consider the height of the patients, they consider the diameter. Still, we don't have a clear-cut rule, but roughly we can say that for males with a height more than 170, we use 39. We rarely use 41. So roughly we can say male 39 and female 37. Unless the female is too much short or the male too much short, then we have to use the lower size, or too much high or tall, then we have to use the bigger size. But roughly, male 39, female 37. This is the right double lumen tube. I didn't use it any time in this hospital. We never have a procedure in the left main bronchus yet. But this is the only indication for this double lumen tube. You can see here there is a slot. There is a slot. It faces the right upper loop. So when we put it, this slot should face the right upper loop bronchus. Okay. How to confirm it? We go to the bronchoscope. We see the carina. We go to the left side, confirm this is secondary carina. Then we see the cuff, as usual. Now we have to go with the bronchoscope to the right side and face this slot to see the right upper loop bronchus. This is too much, and you can see the slot is not, and the cuff is blocking the right upper loop. This causes a lot of problems. If you're isolating the left side, if you have procedure here, and you are blocking the right upper loop. If you isolate the left side, then you are ventilating the right side. You are not ventilating the right upper loop. So you are ventilating only two loops on the right side. You are isolating the left side and right upper loop. So the patient has a big chance to have hypoxia. So confirming this position is very important. Now coming to the other means of lung isolations, Fogarty had been used. Not been used in the 80s actually. This is how to isolate the left side, or the right side. I'm not talking much about it. This is the Univent. The Univent have anterior slot for the bronchial blocker, with the reading for the height of the mark of the bronchial blocker. It's anterior, and if you look at the tip is not straight; it's flexed. So to isolate both, how to manipulate? You can just rotate it from up, so the tip will go to the right side, or left side, or right side like this. These are some readings, very important. I want to show you here that in the tube 39, which we use in male usually, the outer diameter is 13 millimeter, while in the size 9 single lumen tube, outer diameter is 12.1. We use usually in male, single lumen tube is size 8. Size 8, outer diameter is 10.9. Look at the 39, it's 13 millimeters. How much bigger? But look at the inner diameters, we can see that bronchial diameter is 4.9 millimeter, 4.9 millimeter. If you go to 37, 4.5, 4.7. So the bronchoscope which you have to use in the double lumen tube is smaller than the other one, the single lumen tube, because the inner diameter is small and D-shaped, it's not round shaped. Okay, this is the Univent. This is how they use it on the right side. You can see half of the cuff is outside. Why? Because the right main bronchus is almost straight with the trach. And the other thing, we don't push it deep, because if you push it deep, you will miss the right upper loop. The left side, you can push it deep, no matter, because you have long left main bronchus. This is different kind of bronchial blocker. We have Arendit, we have Fuji. I don't know if we have Fuji here. We don't have Fuji. I think we have Cohen. We have Arendit. It's elliptical shape. It's like a matra. So when you put it in the right side, it will inflate it here, and it will not block the right upper loop. Okay. We have 3 sizes of Arendit, while we have only one size of Cohen. Cohen is 9 French. It should not be used in tubes less than 7.5, while in size 7 French and 5 French, 5 French we can use it in pediatric with a tube of size 5 minimum. Okay. Here you can see the right upper loop. It's most likely missed in the right side, that the right upper loop is not blocked. How we use it? First of all, in the connection of the okay. Here's the connection of the Arendit blocker, and it's the same for the Cohen. We have one port for the bronchoscope. We have one port for ventilation and one port for the tube, and the other side for the bronchial blocker. And there's a locker here, so we can squeeze it and lock the canter. It will not move. Here we hang the bronchoscope. We hang the bronchoscope with the loop at the tip of the bronchial blocker. We hang it and we pull the snare from outside, so it will be one piece. Then we go together with the bronchoscope and the bronchial blocker. We go with the bronchoscope to the left side if we want to isolate the left side. Where you want to fix it, in the left side, then you lose the loop here, the snare, and pull the bronchoscope up to the tip here to see the cuff where it's inflated in the left side. This is Cohen. Cohen had router here outside, so it flicks the tip, anterior and posterior, then you can manipulate to the tip. Fuji, it's already flexed like the univent, so we can manipulate it. Just it came from the cath lab. If anybody working with the cardiac patients in the cath lab, you see their catheter, it has a tip like this. They can manipulate it wherever they want. This is the patient which had upper loop, prematurely emerged the right upper loop. And this is how you see it in the bronchoscope. You can see the carina, and you can see another lumen here. This is called trifurcation or tracheal bronchus, sometimes they call it. This is some anatomical variations. You can see here the right upper loop. It comes from the trachea, while the carina is between the left side and the left main bronchus. This is a case of scoliosis where it has left upper loop emerging separately from the trach. Now this is the case, patient has pneumonia before, right side, pneumonia, so he has only one lung. Then he came for another procedure in the lung to have wedge resection. So the right side is already gone. They have to ventilate the left side and at the same time isolate. So they put the catheter, the bronchial button in the left upper loop and isolate the right upper loop only and ventilate the lower loop. So this is how it looks like. It's the bronchial button in the right upper loop, left lower loop, sorry. The left upper loop, sorry. Left upper loop is isolated. Left lower loop is ventilated. This is the stamp of the right main bronchus because the patient has pneumonia in the right side. If you have patient in tracheostomy, what's the solution to have lung isolation? Either to use the tracheal or bronchial blocker through the tracheostomy cannula, or we can use development tube from outside and pause this till they finish. Now, why complete fiberoptic exam is required? The answer is simple, but we don't do this now if you have CT scan. We study the CT scan before we start the procedure. I asked my resident or my assistant to have a look at the CT scan and we look at the bronchial tree to see if there is any abnormality. Now, many studies have been made for anesthetists who do not do regular anesthesia lists, and usually before the introduction of the fiber optic, when we were using the double lumen tube with the Hawk, the rubber one, I don't know if anybody remembers it, we didn't have bronchoscope, we just auscultate. With the double lumen tube, we hit the left side, then we auscultate. We isolate one and auscultate. Okay? And see with auscultation if the isolation is okay or not. Now we brought the different number of anesthetists and they have done this and auscultate and confirm the position. Then we brought another anesthetist, expert one, to do fiberoptic bronchoscopy and see the position of the tube. We find that 35% were not positioned correctly. Another study, they found that 56% have not been confirmed the position. They have malposition, while the anesthetist said the position is okay with auscultation. So the fiberoptic confirmed that there is 56% there is malposition. And if you proceed with this malposition tube, most likely you will have hypoxia. Let me tell you a case. There was a case of scoliosis anterior approach. Lineoscoliosis, usually they are young patient, adolescent, and anterior approach, that's in the scoliosis in the thoracic side, the upper side. They go anteriorly with the left side usually. And we put the bronchial blocker. I just went in, it was not my theater. We went in and we put the bronchial blocker in the left side. It's really confirmed that it's in the left side. And when we auscultate, we see the air entry bilateral. Now, when we look at the CT scan, we found that because of the scoliosis, the right lung is crossing the midline to the left side, which we want to isolate. So when we are auscultating, we are auscultating the right side, which is crossing the midline. Okay. So fiberoptic bronchoscopy is very important in this situation. Right upper lobe or right middle double lumen tube, in 89% you will have malposition. Then you have to confirm it. Show you something here. Yes, with flipping the patient from supine to lateral, usually when he's supine, he's flat on the table. It has some flexion in the neck because the occipital with the back is on the one side, so it will be like this. When you become a lateral, it will be in neutral position. Okay, so there will be change with the neck. Usually in 25% you have malposition after positioning the patient on the lateral side. And you have 25% of malposition after confirming the position of the tube intra because of the manipulation of the surgery, especially in the right side. So you have to keep the bronchoscope all the time in the theater, because anytime the isolation will be lost and the patient may become hypoxic anytime. To confirm the position is the fiberoptic bronchoscopy. Now this is some general advantages and disadvantages of different means of the lung isolation. Very important in this study that it shows that overall clinical performance seems to be similar for all three devices: the double lumen tube, the bronchial blocker events, the lung isolation. It's almost in overall it's almost the same. But the problem is the bronchial blockers. It takes some longer time, especially the left side. Take longer time, minutes. And in the right side, we have more failure because here excellent isolation. You can see the right main bronchus because, as you said, the position is quite tricky, and the right main bronchus is short, so with manipulation it moves somewhere, so the isolation will be lost. So why we need fiberoptic bronchoscope for lung isolation? I think this is a silly question. The question is, shall we practice thoracic anesthesia without fiberoptic? Why we need fiberoptic, or why it's mandatory? Now, we have the right side double lumen tube. It's mandatory. We have to use the fiberoptic. We cannot adjust it without fiberoptic. We have the persistent division of the contralateral, as we said before, when the tube is all the time going to the left side. No matter what you do, it goes to the left side, the right side. Sorry, double lumen tube goes to the right side, while you want to do it in the left side. Then here's the role of the fiberoptic bronchoscope: difficult intubation, and the video assistant thoracoscopy. And video assistant thoracoscopy, this is very important. I want to focus on this. Now we have 65 to 70% of our procedure is thoracoscopy. Here you don't have a choice. You have to isolate the lung. You have to get a good isolation. Otherwise, the patient, the surgeons will not have exposure. He will not see anything. Before the introduction of thoracoscopy, there is only 3% have absolute indication for isolation. Absolute. You have to isolate, no matter. Air, blood, and pus. When the infected lung has pus, and you have to protect the lung, then you have to isolate. This is absolute indication. When the one lung is bleeding, have pulmonary hemorrhage, then you have to protect the other lung of the blood. Then you have to get isolation. When there is a bronchial fistula, bronchopleural fistula, big one, then you have to isolate the other lung to protect the other lung. This is the only indications, absolute indication. Now this is before the introduction of thoracoscopy. Now imagine now you don't have fiber optic and you have done thoracoscopic procedure and the isolation is not correct, is not good. The surgeons cannot see, he cannot manipulate the lung. Then they has to open and retract. It's not acceptable to change the procedure from thoracoscopy to open because you don't have bronchoscopy. Now we can say this concept is completely changed. Now the absolute indication is more than 65% because of the video system. Now I'll come to the conclusion. Fiberoptic bronchoscopy is an essential tool in thoracic anesthesia. It requires proper equipment, which we have it. We have to recognize the tracheobronchial tree, and we have to learn it. And we have to master the recognition of right upper loop, bronchus. Okay? One should certain that the tube is optimally positioned throughout the procedure. We teach the residents that we have to do the bronchoscope to confirm the position. Then when we flip the patient, we have to confirm the position again, especially if you are doing, if you are putting bronchial blocker. We have to practice bronchoscopy in routine cases of all anesthesia simulator. This simulation I present, it's in the site, it's very nice, and anybody can access it in the site at Thoracic Anesthesia from Toronto. Thank you for your attention.
Thank you, Dr. Rifai.